Greetings my dear friend, my name is Maxim and welcome to my channel, and today we are going to be discussing glucose transport across the membranes. This is part 3 of the sequence of lectures regarding this topic. If you haven't seen part 1 and part 2, you can use this link for your studying pleasure. Well, without further ado, let's enjoy the lecture and dive into it. Glucose transporter type 2, also known as solute carrier family 2, or facilitating glucose transporter, member 2, located at SLS2A2 gene, is a transmembrane carrier protein that enables protein-facilitated glucose movement across the membranes. It is principal transporter for transfer of glucose between liver and blood. Unlike glucose transporter type 4, it does not rely on insulin for facilitated diffusion. This transporter is distributed in liver, beta cells of the pancreas, hypothalamus, small intestine and renal tubular cells. GLUT2 has low affinity, high capacity and high Km, between 15 and 20 millimolars. It also acts as glucose sensor in beta cells and hypothalamus and carries glucosamine. Clinical correlations include FANCONI-BICKEL syndrome, which we are going to discuss later in this video. In rats during gestational diabetes, in which glucose levels are uncontrolled, neural tube and cardiac defects in early developing brain, spine and heart depend upon functional GLUT2. Preventing edema-induced stroke and trans-ischemic attack in stress hyperglycemia. It also associated with overall survival in patients with hepatocellular carcinoma, a new prognostic factor for hepatocellular carcinoma. After a large amount of carbohydrates rushes into the intestine and glucose concentration reaches 30 millimolars, glucose transporters type 2 are embedded in apical membrane and allow glucose to enter enterocyte via facilitated diffusion. If we are talking about beta cells of the pancreas, glucose enters the cell via transporters and the glycolysis process takes place and ATP molecules are created. Normally, resting membrane potential is created by means of ATP-sensitive potassium channels and is approximately -70 mV. However, our ATP molecule blocks these channels, thus depolarizing the cell, making it less negative. After which the voltage-dependent calcium channels open and the calcium rushes inside the cell. And eventually insulin-containing vesicles can bind to the snare proteins and insulin is excreted. Important note: sulfonylureas block ATP-sensitive potassium channels, causing depolarization and insulin secretion. In the liver, I want you to remember that our transporter can work in two directions. For example, when the level of insulin is raised, it stimulates the synthesis of the glucokinase, with the subsequent formation of triglycerides from glycerol and fatty acids, which will be packed in vesicles called very low density lipoproteins and in fat tissue capillaries. Under the influence of lipoprotein lipase, free fatty acids can be stored in adipocytes. On the other hand, during fasted state, gluconeogenesis and glycogenolysis create glucose 6-phosphate, which under the action of glucose 6-phosphatase turns into glucose and through glucose transporters type 2 is transferred from the cell to the blood. FANCONI-BICKEL syndrome, a rare glycogen storage disease due to a deficiency in solute carrier family 2, GLUT2, and characterized by hepatorenal glycogen accumulation, also known as glycogenosis, leading to severe renal tubular dysfunction and impaired glucose and galactose metabolism. Clinical onset occurs during the first few months of life, with failure to thrive polyuria, normal hypokalemic metabolic acidosis, fasting hypoglycemia, proximal tubule dysfunction, leading to metabolic acidosis, hypokalemia, hypophosphatemia, and rickets. Hepatosplenomegaly resulting in a protruding abdomen are evident by early childhood. Puberty can be delayed. Generalized osteoporosis can lead to fractures during childhood. Abnormal fat distribution can be seen. Diagnosis is done via identification of mutant gene SLS2A2. Treatment: replace water and electrolytes, vitamin D, galactose-restricted diet with fructose as the main source of carbohydrate, during infancy, night feeding to avoid hypoglycemia. Well folks, this is all what I have for you today. Thank you for watching, and if you found this lecture helpful, please leave a like, comment down at the comment section, and subscribe to my channel. I wish you a very lovely day, and see you guys later. Goodbye.